I'm sharing my screen now.
Lenovo tab.
Okay.
Can you see my screen?
Yes.
Just I'm taking few minutes so that all the things I can. Okay, I'm just a few minutes. I want to. Can you see my screen clearly?
Yes.
Dr. Nazmul
Yes.
Yes. With the permission of Professor Bari, I am just starting my session. And all the participants from home and abroad, Assalamu alaikum. I welcome you all to today's basic ILIZAROV session webinar, lecture 9. And so far, those who have attended and connected to us, known it well that we have completed the history of the ILIZAROV surgery. We completed all the basic component, and also today is the last lecture on the anatomical consideration of the lower extremity that include the ankle and foot. I am Dr. Arifuzzaman on the behalf of Bangladesh Kurgan Fellow Group presenting my papers. This is a very great quotation from Leonardo da Vinci. You know that Leonardo da Vinci does not need any introduction. He is the biggest philosopher, scientist, from Mona Lisa to the aeronautical engineering. All are the things he explained very nicely 600 years ago. According to the Leonardo da Vinci, the human foot is a masterpiece of engineering and work of art. And today our session is on the foot and ankle. And foot and ankle, we want to correlate the biology, the biomechanics, and the ILIZAROV biological osteosynthesis technique in all the things in a single lecture. So let's explore the foot and ankle of human body. And I added this slide from a picture in the web. It is a random picture, and it says the stop for hope. And now at the time of Corona, Bangladesh is at the very peak of infection. So far, over 60,000 Corona positive patient in Bangladesh. So we are just stuck. We are just stopped, but we stop for the hope. And going to my presentation, I want to give you a little idea how the human foot is. If you see the footprint, the human footprint is so that all the parts are not in same plane. So that when a foot is on the ground, some part touches the ground, some part doesn't. So from this, we can get a very preliminary idea that all the bones and all the soft tissues and other vital structure of the foot are not in the same plane. So the basic is that when we performing ILIZAROV, when we introducing the wire, we should keep all the scenario in mind so that we can get a good 3D picture and have a good ILIZAROV fixation. Now go to the anatomical details. I divided my lecture into parts so that some parts is osteology, some parts is joint consideration, and some parts is biomechanics and my clinical case sharing. And if you see in the foot of a human being, you can see that it is very well known to us that our foot is dome shaped. It has the arch, but the arch is so that the medial side is relatively a higher level than on the lateral border. So please keep this in mind that when you put the wire, then the wire would not be as vertical or as parallel to the body part, as we have told you that in other part of the body we try to put all the wires in the long axis of the bones or vertical to the bones or some other consideration. But here the bones are so designed that you have to put all the wires in a direction that can fix all the bones, and bones are not collinear here. Bones are arranged in a different manner in foot. So you should keep all the things in mind during wire fixation. And what is that? I have, if you follow my curvature, you can see that if you cut a bones just in a coronal plane of the foot, then any cut take some part of the tarsal bone, some part of metatarsal bone. Even cutting in a coronal plane, all the tarsal bones are not in same level. So there is the anatomical variation of orientation of the bones in the foot. Even you see that the first metatarsal is very thicker. Even if you pass the wire at the bottom of the first metatarsal bone, then it will miss many of the bones. So to fix all the bones, you should be meticulous and you should be directed as the anatomical arrangement is. So now go to the another part. And another part of the ankle is that talus is in the ankle mortise. So if you want to put wire in the talus, so very little part of the talus is exposed to the surface so that you can put the talus without fixing the joints. If you see in the lateral part of the talus, that the most of the talar lateral part is covered by the articular surface, which is articulate with the fibula, but the medial part is more exposed than the lateral part. Medial part, there is a small articular surface. Why I am telling this? I am telling this as because both the surfaces of the talus, even the neck of the talus and the exposed part of the talus is very much subjected to the wire introduction. So you should know, I know that you all know very anatomy very good, but here is some little bit different consideration so that you can introduce wire very precisely. And also if you follow my curvature, also the ankle capsule attachment is like that, it through the rim of the talus. I request everyone, please unmute your microphone, mute your microphone. So now I am going to the another slide. This is the consideration of the talus during the wire fixation, and I will go for the cross section of the ankle a little bit later. Before I go to that, I want to focus some very basic normal anatomical structure of the foot. And this is the longitudinal arches, you know that, but my emphasis on this picture is that if you see in the osteology, the joint plane, if you see the mid-tarsal joint plane, it is little bit oblique, and you see that mid-tarsal bones is some of triangular shape. It is triangular apex is in the cuboid bones, and the base on the navicular and the middle cuneiform bone. So if you want to fix only the mid foot, then you have to put your wire in a different anatomical consideration. So please look how the joints are arranged here. And as I have told you that the talus is mostly articular, but some part of the talus is still subjected to the wire fixation. That how it can be. If you see the anatomical, the tendons and other tendon sheath, if you follow the lateral malleolus, there is some area of the lateral of the ankle that is devoid of any important structure. If you follow my cursor, this is. Even on the medial part, some part of talar area is also devoid of important structure. Here there is deltoid ligament, different layers. So very little part of the talus is exposed for putting the wires, but the talar neck and the some part of the body of the talus is exposed, or you can give the wire very safely, talar wire by through this region. So I am comparing both the osteology and the soft tissue side by side. And then if you visualize the foot from the anterior, from the dorsum of the foot, that is, there is a line, the midpoint between the two malleolus and the web space, first web space. If you draw a line, the tibial dorsalis spinalis artery is in the line, and the width is nerves. So don't put any wire in this line. If you just avoid this plane, then you can avoid many important structure in the foot. This is one consideration. And here I just want to simplify the foot anatomy, as because I draw some windows. If you see from the medial side, that inferior window, that is the posterior inferior part of talus, is devoid of any important articular, any important critical structure. Also, just in front of the medial malleolus, this area, if you follow my cursor, this area also devoid of any type of important structure. And there is a radiological triangle. One point is navicular bone, one point is the tip of the medial malleolus, one point the tuberosity of the calcaneum. This triangular area is very much vulnerable for this posterior tibial artery and nerve structure to be damaged. So which part is free in calcaneum? The posterior inferior part, or most posterior part of the calcaneum, is free for putting anywhere. So this critical triangle and the safe window you should keep in mind during the wire fixation. And there is a personal trick. If you put your finger just behind the medial malleolus, if you feel the pulse of posterior tibial artery and draw a straight line, the area just posterior to the straight line is very much safe. You can put the calcaneum wire very safely in this area. And I draw it for you. If you look at surface marking of the foot, and what are the areas safe? If you just diagram it at a triangle or a quadrangle, you can put the wire very easily in these areas. There is no vital structure is there. And you should not penetrate any joint area and other nerve area also. So this window or this triangular or the quadrangle area is relatively safe for placement of the wires. So now I have completed the anatomical, some surface anatomy and some nerve and vessel relationship in a foot. And as I told you that I will go for the cross section a little bit later. Before going to the cross section, I want to emphasize some very important thing. Frequently during the foot correction or any foot deformity correction or any purpose, you need to need some percutaneous type of tenotomy, like the plantar fascia, flexor tendon, and tendon Achilles. So I want to just give you some ideas about some clinical details. If you see the plantar fascia span from the calcaneum to the toes, and like this fan-shaped manner. And you see that the plantar fascia is the most superficial part in the sole of the foot, and it acts as a bow sting. And what is just under the plantar fascia? If you layered your foot, you know that very interesting anatomical concept is that in foot there is 4 layers. So just after the plantar fascia, there is the small muscles and the branching of the nerves. And if you follow my cursor, this area is just anterior to the anterior to the calcaneal attachment. This area more or less safely you can put the needles, you can put the needles, or you can do the percutaneous plantar fascial resection in this area very safely. So don't be very worried or afraid of doing percutaneous plantar aponeurosis resection in case of when there is a cavus foot or very tight plantar aponeurosis, because if you do this type of resection, it will allow you to very rapid correction. Otherwise, this tethering, skin tether, or this type of soft tissue tether will delay your correction and produce a very much destruction resisting force. So this thing you should keep in mind. And plantar fascia resection is not a very difficult thing to do if you know all the anatomical details. And usually this type of plantar fascial resection come from the original steindler procedure. Though in ILIZAROV surgery we put only 15 size BP blade, so that we do all the thing percutaneously, and you feel the tight structure and just micro resection or fractional resection of the plantar fascia. These things are very much important during the cavus correction. Another thing that when you correct a very old deformity, there is some clawing of the toes. To prevent of the clawing of the toes, there are several techniques. Sometimes you need to capsulotomy of the metacarpophalangeal joint, metatarsophalangeal joint, and also lengthening of the flexor digitorum tendons. This thing, just if you know the anatomy, or you can do it very precisely by simple stab incision. And other thing is that frequently we incur during during equinus correction, that is the percutaneous lengthening of the tendoachilles. And if you see from the posterior side of the heel, the medial side or medial border of the tendoachilles is just close to the artery and nerve. How can you do it very safely? Just put your the 15 size blade. If you are very much experienced with doing this in CTEB, but here is something different. You need a step cut type of percutaneous tenotomy in tendoachilles. You know that there are different methods of performing this. By I am just what we are doing and what I am used to. I am just showing you. Just put your blade just medial to the tendoachilles, and go to the half of the tendoachilles, and then do a distal transverse incision, transverse cut. It is very safe because there is no vital structures there, and just stress your tendoachilles that it will slide itself. So this type of lengthening usually we have to do in a case of ILIZAROV fixation. So I think this type of anatomy is very much necessary to keep in mind during doing ILIZAROV and all the small percutaneous procedures. So I just complete the other anatomical details, and I'm going to the main part, the cross section and the wire placement. Before going to that, I want to just focus on some important anatomical landmark, how the foot, normal foot is in X-ray, and how the axis is. You need not to memorize all the axis, but you need not to memorize. Usually the calcaneum is 28 degree, but for your easy memory, I want to say that it is 30 degree to the transverse plane. The axis of the calcaneum, normal foot, always 30 degree to the transverse plane. And talus, how the talus is inclined? Talus is inclined around 24.5. You can say it that 25 degree. So this is the normal alignment of the calcaneum and the talus in relation to the normal foot. And why it is important? sometimes you say that the externally the foot is calcaneal. Okay, yeah, the foot is the equinus. But if you do a radiograph, you see that this equinus can be contributed by the many factors. Maybe the midfoot is breakdown, so midfoot also cause this some form of equinus, and also the hind foot, the calcaneum is high up, so it can also cause the equinus. So if you have a good X-ray and you have the knowledge how the foot bones are aligned in which angle, then you can easily just find out the importance of doing a procedure in any part. When you have to put more importance in the calcaneum or correction of the equinus, or you have to just give more importance to the midfoot, then you can easily calculate it by if you keep in mind this type of normal anatomical axis. So now I am coming to the cross section. For your easy memory and to realize it very nicely, I just arranged my this lecture is that I get some CT MRI scan of different level, and I just correlate all the things in a single slide. So I will go a little bit slow so that you can easily understand all the things. And on the black photograph, everyone is familiar with this. These are the MRI scan of the foot and ankle. And on the left side, it is sagittal, coronal, and 3D section where the section is. And with this section, I just correlate some of the paintings or some of the figures from the books that we are using for reference. So my first cut is just at the level of the just above the level of the ankle. In above the level of the ankle, how the main important thing is that how the lateral malleolus is arranged with the tibia. In the in the sulcus of the on the lateral side of the tibia, there is a gap and there is an even gap. Always in MRI scan and other thing, this is the relationship between the fibula and the tibia. And from the previous lecture of Dr. Munir, you know that on the just above ankle wires, we can put very easily by dividing this area into 3 parts. The lateral 2 part, I am just showing in the cursor that this 2 arrow is lateral 2/3, and you can put the wires very easily through this. And if we go, what are the direction of the wire can be? You can put from here, from fibula, holding the fibula and exit to the tibia. You can go transversely, and you can go in this direction. Because this areas is more or less subcutaneous, so you need not to worry about the danger of piercing the major vessels. Just keep in mind that anterior third is dangerous. So if we go a little bit lower cut, this cut is at the level of the malleolus, 2 malleolus. Here, there is the thing that if you see the axial cut of the ankle at the level of both malleolus, then you can see the medial malleolus and lateral malleolus are arranged like this. If you want to put the wires through the, and if you recall my lecture of the safe window, that in front of the lateral malleolus, in front of the medial malleolus, there are area where it is devoid of any vital structure. So you can put the cross wire in the talus by this manner. But you should keep in mind that just posterior to the medial malleolus, there is the posterior tibial tendon, and the lateral malleolus, and there is the peroneal tendon. So you have to avoid this and just feel the tendons and other things, and then you can put the talar wire if you want to. Sometimes talar wire we need to put in case of arthrodesis or other issue. So you can put these wires very safely by this manner. And if I proceed a little bit, and this is the cut. If you just see in the left side of the where the cut is, this cut is around the neck of the talus. And what is look like in MRI? This is the talus and this is the navicular bone. And if you want to put the wire in the talus, you are free, and you already have gone through the safe window around the talus where we can put the wires, and I already showed you the articular consideration and the area devoid of any articular cartilage or soft tissue around the talus. You already know that. So I'm going to the next slide, and it is at the level of, I already told you that the foot structure is a little bit oblique and little bit in a step-like manner. The medial part is high up and lateral part is lower down. So you have to direct your wire according to anatomical consideration. If you cut, I already told you that if you cut in direct coronal, then you can get some part of the tarsal and some part of the metatarsal bones. But you have to be oblique to process all the bones. Here, if you cut like this in an oblique manner in the cuneiform bones, then you can get all the cuneiforms and cuboid. You can fix all the cuneiform and the cuboid in this manner. Why it is important? Sometimes you have to correct the midfoot, distract the tarso-metatarsal joint and other thing. So you have to precisely hold all the tarsal bone. So for this reason, you can put the wires like this. And now I'm going a little bit forward to the toes. That is this wire at the level of the first metatarsal bases. Metatarsal bases, but you see that I already told you that first metatarsal is little bit thicker, but other metatarsal, if you put any wire at the lower part of the first metatarsal, frequently it misses all the wires, all the metatarsal. So you have to keep all the anatomical consideration where if you want to put the wires in the little bit dorsal direction of the first metatarsal, then it will process other metatarsal also. So this anatomical consideration is crucial during fixation of the ILIZAROV wire. And so same thing is repeat in another view, that just follow the lower wires. If you want to fix the first metatarsal at the plantar surface, more at the plantar word, then you miss other metatarsal. If you want to fix all the metatarsal, then your word direction should be a dorsal word. So this thing, anatomical consideration, you have to keep in mind. And other is that around the base of the tarsal bones, the bones are not in the same plane, but at the distal part of the metatarsal, the arches is flattened, transverse arch is flattened. So more or less all the bones and the neck of the tarsal bones comes to a little bit same plane. Even putting the wires here, one important thing is that you sometimes, if you want to put wires through all the bones, you have to press the metatarsal head to flatten the dome, so that you can process your wire through all the bones. What is like that? This type of flattening, you have to push the metatarsal head to bring it in a same plane. This is nicely demonstrated, and if you follow the picture, then you can get the idea also. So if I just summarized my direction of the wires, so you can put the talar wire in a coronal plane. It's not a very different problem. But if you want to put you hold the navicular bones and the cuboid, you have to go a little bit oblique manner. If you want to hold all the cuneiform bones, you have to go more oblique. And other thing is that you cannot put a coronal plane wire in the forefoot, because if you put coronal plane, then one base and other shaft will be in a line. So if you want to put the wire very securely, you can put a oblique manner. That is, and also anatomical consideration is that the first metatarsal bones is relatively thick and short in comparison to others. This type of anatomical consideration you should keep in mind during the wire fixation. So these are the ideal direction in a nutshell to fix the foot. And also you can fix the toes also when it is necessary, because of in case of old equinus correction or where there is clawfoot, I already told you, you can put the wires in such direction so that you have to fix the metatarsophalangeal joint also, from the tip of the toe to metatarsophalangeal also. These are the wire you can, these are the direction you can put your wires. So now I'm coming to some ankle tricks of assembly. I complete the basic anatomy, cross-sectional anatomy, and compare it to all the 3 parameters, sagittal, coronal, and the 3D sections. So now I'm going to some ankle tricks of assembly. What are the ankle tricks of assembly? If I refer you to my previous lecture L2, you can got the idea of ankle center rotation. I do not want to repeat you. You can get all the things of what is ankle center and why it is important. You can get all the idea from the previous lecture. And now I just want to simplify this figure for you, that think that this is the equinus foot. I already told you that axis of the calcaneum usually 30 degree oblique, 30 degree oblique to the horizontal plane, and it is facing, it is in the downward direction. But in the equinus, this thing is reverse. The axis is parallel to the normal axis. Calcaneum axis is parallel to the normal axis. And if you want to put the ring in the calcaneum for correction of the equinus, you have to consider this type of normal angulation of the calcaneum, and your direction of the ring should be in 28 degree 28 to 30 degree angulation with the transverse plane. Think that this blue line is for transverse plane, and this red line for the this red line is for the ring direction. And I request everyone, please unmute your microphone so that the noise is less. And sorry for interruption. I request the co-host, please unmute the microphone of our any participant that producing the noise, as I am in the speaker mode. And what is that? I was there. Is that the normal axis of the calcaneum, when the equinus is there, it goes relatively parallel to the plane, parallel to the transverse plane, and you have to put the ring in a oblique manner with the parallel to the plane. And how you should put the distractor? And you should put the distractor in such a manner so that the distractor is directed a little bit posteriorly. Why it is important? I will tell you that the direction of the distractor is a main component to prevent the anterior talar subluxation. So what will cause the anterior talar subluxation? It is very much common thing if you mismatch the hinges, if you mismatch the distraction rod. What is tangent? You can get in many books that you should put the distractor in a equinus correction in a tangent manner. Tangent means it's a line which touches a circle just at one point. It do not cross sect it, just touches a point. So if you think the center of rotation of ankle is in the point lateral to just tip of the talus, and the distractor should be a transient manner, like a circle, not crossing this. If it crosses this, like this picture that I labeled with cross, if it crosses the circle, then what will happen? You see that there is a distraction force F. This F will dislocate the talus. And this is the practical representation how the talus get dislocated if you do not consider this tangent thing during your distractor placement. And if it is goes just a straight distraction, then there is the anterior talar subluxation. You should put the distractor in a oblique manner. And now I am going to some foot correction technique and how the wires you should put. If it is an adduction deformity, there you must a lever to block the displacement of the foot, and you can put the you correct the medial. You can correct the adduction by tightening these rods. As you gone through the previous lectures, how can we use the slotted rod? We already discussed. So another example, forefoot correction. These two wires. I already told you that if you want to put the wire in forefoot, you have to you keep mind in all the anatomical details of the forefoot, and you have to put the ring also in the axis of the foot during the deformity correction. What is the axis? The second metatarsal is the axis, and the ring should be perpendicular to the second metatarsal, whatever the wire direction is. So this is a very important tips during the frame assembly in foot. And now I just draw some pattern of calcaneum wire, 1, 2, 3 pattern. You can choose any of these according to the anatomical consideration. That is, sometimes you may need to put the olive because the calcaneum bones is very spongy bones. Sometimes the wire are cut out, and if you put the wire in the same plane around the calcaneum, then it can also make the holes in the calcaneum if it got infected. And sometimes to prevent this type of movement or side to side movement, sometimes you may not to put the wires in a great direction like the 60 degree or more. And usually you have to put around 30 degree or less than 30 degree. For this reason you have to put the olives also, and you can put a console wire to prevent this togging effect, and this will prevent the side to side migration of the ring if the angle is less. And here another configuration, you can put 2 parallel wire and 1 oblique wire in calcaneum, so that the stable fixation is there, because in case of equinus correction, there very much force is generated in the distraction rod, and your calcaneal fixation should be a stable one, so that you can just resist this type of distraction force. And now I am sharing my clinical experience and the correlation of what the things we have just learned from our previous 8 lectures about the ring frame assembly and anatomical consideration. And this is a patient of mine. He is 25 years old when I operated him, and he had a history of very bad childhood osteomyelitis and after road traffic accident, and lost many muscle bulk at the anterior at the back of the leg, and after that he developed the bad scarring and equinus. And at the time of operation, my patient is also married, and I operated him at the 25 years old. What I am telling that he is married, I will tell you a little bit later. So this is his X-ray. I always do a normal leg X-ray scan for right leg, and it's for left leg. And the thing, sorry, please unmute your microphone. This is noise. And what is that? Sorry, I am just okay. That the noise is less. And what I am telling that in this equinus foot, you see that I already told you that normal calcaneum axis is 28 degree below the transverse plane. But what happened here? The calcaneum axis is already maybe the 28 or 30 degree above the normal transverse plane. And this is a very stiff and very old equinus, and you have to go very meticulously. And the left side is his pathological part. And I just want to correlate the previous things. Already I told that this is the axis of the calcaneum, and this is the normal axis of the, this is normal horizontal axis. If you follow my cursor, then what is happened here, the normal angle is reversed to the abnormal angle and above the level of the normal transverse plane. So what I have done, and I told you that it is a place where we can correlate with the previous structure. This patient is very motivated. He done all the lecture, all the dressing with the rubber stopper and the gauze piece. It is very vital thing during doing ILIZAROV, and these hinges are placed in a very meticulously. And most important thing, I want to show you that the placement of the distraction rod in the calcaneum. The distraction rod calcaneum is posteriorly directed. So I am trying to make it transient to the circle of center of rotation so that the anterior subluxation of the talus will not happen. One thing I want to tell you that even putting all the caution together, sometimes you may encounter there is also dislocation of the talus. So you go to a serial X-ray every weekly or 2 or 3 weeks during the distraction process, so that you can correct that if any chance of dislocation of the talus during correction procedure. So I am telling you that even after full precaution, sometimes the dislocation can happen. So you have to counteract this. It is not a very difficult issue. And another thing I want to emphasize that I put the toe wire for the patient and hold it with a long plate and with the ring. So hold with the long plate and a ring. Why I am showing this, I will tell you later. And even during the correction is going on, the distraction rod, sometimes the distraction rod is bended. So I make it a strong on by putting a sleeve of like telescoping rod. And also this direction of the distraction rod is still posteriorly directed. And you have to take the serial X-ray so that you can prevent the subluxation. And after removal and correction, and I always put this type of splint. This is very much indigenous made, custom made orthosis in my place. And you see, just two things I want to mention you, that I put a little bit higher up block at the anterior part of the sole of the foot, anterior part of the sole of the foot, so that the recurrence of the equinus is not did not happen. And also I increase the lever arm of the anterior footwear. You know that in long standing equinus in CP patient, there is weakness in the anterior muscle, and if you put a long lever arm, then the ankle, the weak muscle can work a little bit with a little bit comfort, so that the foot stepping is good, and you can maintain this for some times. And this patient is very happy. As I told you that the patient is married. The patient got married when he had this type of bad equinus, and after that his wife came to my chamber, and the smile of the patient and his wife just give me very peace of mind that they overcome all the deformity and living a happy life. Now, in my postoperative etc. after removal of the ring, you see that the calcaneal axis restored his normal position, and there even it is a very old equinus. Even after the 25 years of this disadvantaged condition, you can see the joint space still is there. This is the beauty of ILIZAROV. This is the beauty of deformity correction. You have to meticulous and you should respect all the things of the biomechanics and biology. And now the last tip from myself, the toe tip consideration. The what is toe tip consideration? The toe tip consideration is like that. I told you that when there is a bad equinus, the chance of clawing or bad clawing is already there. You may put the wires in the toes up to the metatarsophalangeal joint. But you know that our toes are a anastomosis of the arteries. If you press any part of the toe, it will you can observe the capillary refill phenomena there. But if you put the wires in a very pressurized manner and if you compress the soft tissue, then this compression can cause some micronecrosis around the tip of the wire. So this thing you should keep in mind during the wire fixation in the toe. My recommendation is that just put a small stab incision and introduce your wire. So by this simple technique, in foot or in nail bed or in finger or toes, you can avoid this type of fingertip micronecrotic hollow. Usually this is very common thing if you do not consider this type of things during his wire fixation. And lastly, this is a picture from Kurgan Center. Their assembly of the foot for at the end of the treatment procedure, they are just trying to remove all the assembly from the foot. You see that all the wires through the foot, all the to the toes, and there is the good correction is there, and how the assembly every hinge. It is a work of hinge and work of joints in case of foot. And so, on my clinical practice, usually sometimes I just make a count that how many hinges, how many posted it needs to correct a foot. Usually the number is around 40 to 50 or 60 numbers, whatever may be. You have to prepare with good number of different size of post during correction of your foot. So I am just end of my presentation. So now the take home message, now the stay home message: respect the biology, consider about the biomechanical fixation, take care of subtalar joint. I did not say many things about subtalar joint, but the subtalar joint itself deserves a different lecture. A huge lecture can be given on subtalar joint, but my advice is that mobilize subtalar joint as soon as possible. It will prevent many complications of fixation after the removal of the frame. And other thing is that don't dislocate talus during the procedure. That is, stay or keep talus in its motis, that is in its home. And also it is very important message to all of us: stay in home, because the infection rate in Bangladesh is gradually going to a very bad condition. And I pray to everyone, pray to Almighty that He keep everyone up safe and free from the corona. And now the advertisement of the next lecture session. Next lecture will be given by the S.M. Abdullah, Fracture Displacement Geometry and Destruction Osteogenesis. And you can enjoy our lecture in our YouTube, ILIZAROV Clinic, KUMC, Ortho World, or also live in the Ortho TV. And usually Samsuluddha sir from the India usually do the talks about this transmission. As I am today is the speaker, I cannot find the Samsuluddha sir. So you can enjoy my lecture and all the lecture of this Kurgan Fellow Group in ILIZAROV Clinic KMC. And another announcement is that after ending the session, 24th of this month, we will upload some short version of our lecture in the YouTube, only the lecture part, so that if you don't have enough time, you can just go through the lecture very shortly and get all the knowledge. And I will edit some of the part of the lecture so that some disconnection or noise issue can be edited, and you can enjoy all the videos a very audible manner. And now my last slide. Thank you all. And this is my Kurgan group, my favorite group. We are always together, and together we can do many things. So thank you again. And I am ending my slideshow, and I'm going back to the participant and the co-host and Professor M. Bari for discussion about today's session. Thank you all.
You.
Okay. Sir, I just completed my presentation, and I am just, I request everyone, please mute your microphone so that the knowledge is less. We can connect properly. And I think today's the foot and ankle session is very much interesting for the orthopedic surgeons. And I want the good interaction from you. And if you have any question, please send me in the message box, or you can hands up and we can have a good discussion. And before getting any question, I just handed over the microphone to my Professor Bari sir. Please keep talking about the ankle and foot things. And if you have any opinion, and we can go back to you many times in between the discussion. And now the floor is yours, sir. Bari sir, can you hear me, sir?
Yes.
Yes, sir.
You can hear me?
Yes, sir.
Okay.
I can hear you, sir.
So okay. Now I'd like to pass some comments. Okay.
Yes,
Dear
sir.
friends, Assalamu alaikum.
Why?
And good afternoon, everybody. Today's topic, that is foot and ankle, is very important. We stand on foot, we walk on foot, everything. No foot, no walking. You should have to use the stretcher, or you should have to use the wheelchair. So thanks Arif, he has elaborately described everything. If you think about this ankle and foot, initially you will be astonished that this is very difficult. And I tell you frankly, if you cautiously go through the all the slides that Arif has shown, starting from the ankle up to the hind foot, mid foot, and forefoot. And this is very important part of the whole, if you think about the anatomy of the human body. Here is overall 26 bones in the foot, 26 bones. And in Kurgan Center, ankle and foot department is so rich. Lot of British and Americans, they're coming only to this to learn the ankle and foot. And regarding the structure, passing the wires, he has shown elaborately everything. Any disease, I tell you, starting from the deformity, ankle, foot deformity, post-traumatic deformities, and even the clautos and equinus, varus, cavus, even the hallux valgus, hallux varus, everything you can correct if you precisely follow the anatomy and peripheral, vascular structure. If you know calcaneum, we are getting a lot of neglected club foot, especially relapsed club foot. You have done the PMR earlier, late case, 9 years, 11 years, 12 years, 14 years, boys. When you are putting the wires or olives. In the calcaneum, the triangle, very, very important. Start from the navicular, lateral part of the middle, and muscular area. And otherwise, you don't need to think anything. So regarding the foot, rightly mentioned everything: hind foot, mid foot, forefoot. If you do it, nothing to be worried with ankle and foot. So my request to all the ILIZAROV surgeons is try to learn this foot, and you will be able to correct all kinds of deformities, even trauma. Even I tell you, the late case of Lisfranc joint, 14 days, 15 days, or 1 month or 2 months old Lisfranc dislocation, you can gradually correct this with ILIZAROV. Lot of people are thinking about the lot of muscles, lot of joints, small joints are here. You don't be afraid of that. So my suggestion is, don't think about that. This is very complex, nothing to be worried. You gradually, step by step, you try to learn, and you will be able to correct all kinds of deformities in the foot and ankle. Okay? And now you can invite questions or any suggestions from our national, international ILIZAROVians. You can ask. Thank you very much, Arif,
Thank
for
you,
a
sir.
good discussion, good explanation, good presentation. Okay?
Thank you, sir. And I'm Dr. Nazmul Shidu. Are you? Can you hear me?
Yes, I'm here. I'm here.
I request you to conduct the question answer session.
There's no light.
Oh, okay.
Okay.
Okay, then.
Thank you for your brilliant presentation.
So I am now requesting Dr. Rashid Hassan Rani. I'm watching that he hands up. He puts his hands up for long time. If you have any question, ask me or to the Professor Barisar, or have a good discussion. Rashid Hassan Rani, can you hear me? Rashid Hassan Rani, can you hear me? Yes, yes. So what is your question?
Yes, sir.
Yes, sir. Please. Yes. Do you have any questions, sir?
Thank you, Dr. Yes, sir.
Yes, yes.
Yeah, yes, sir. We can hear you, sir. We can hear you, sir.
Yes.
Audible?
I am Dr. Rashid. Yes, hearing. I am Dr. Rashid Hassan Rani from Kustia. First of all, I convey my respect to my Professor Barisar.
Walaikum assalam.
Dr. Arif, congratulations for your nice presentation, which is delivered in very much informative and collectible form.
Thank you, sir.
Your presentation, you have mentioned and also shown, your presentation, you have mentioned and also shown to hold the calcaneum, putting a concealed wire through the posterior aspect of calcaneum.
Yes, sir.
My question is there any importance or extra advantage?
Yes, sir.
Sir, can you hear me?
Yes, sir. I can hear you.
There is noise.
Please complete.
Okay. My question is there any importance or extra advantage except providing more stability by putting that concealer?
Okay. Thank you, sir. I am answering your question. Please.
Am I clear?
Yes, sir. You are clear. Sir, in my lecture, the different technique of calcaneum wire fixation, you see the different pattern of calcaneum wire. Usually when the heel is very small in size, and you know that in old CTEV, a component of CTEV is that hypoplastic heel, and sometimes trauma or other case the heel maybe the putting the wire in a divergent angle, that is the more stable configuration. You may not put that. Even if you put only the half ring in the calcaneum, then all the divergent wire direction cannot accommodate this type of half ring, a small half ring. So if you do not want to put olive, my personal experience is that sometimes the olives cause the reaction at the entry site, because the olives we are using are just melted with some copper materials and SS materials. So this junction of the olive cause the skin corrosions and also the reaction there. So if you want to avoid the olive, just put two wires. If it is less direction, then you can put a wire in calcaneum from direct posteriorly like a console wire, and usually it increases your stability and prevent side to side tugging. What is side to side tugging? If the angle is less, the ring will just go side by side and it will produce hole in the calcaneum. So you can prevent this by doing this type of another area of fixation. Or even if you put the three wires like two parallel, one cross, you also can prevent this type of displacement of the ring. So I think you got the answer, sir. And if you have anything to say, you can add, sir.
Okay, thank you. Thank you.
Okay, thank you, sir, for the questioning. And if you have any question, I will go for the question. You can send the message to me. And Dr. Ghulam Mustafa.
Yes, we have our
Amir Hussain, sir.
Amir Hussain, I am looking, he's not passing any comment. Amir.
Sir, Amir Hussain, sir, just put his hands up. I asked him to unmute. Sir, please unmute your microphone. I already unmute your microphone.
Thank you, Dr. Arif.
Yes,
Arif,
sir.
I have a question to you.
Yes, sir. Thank you, sir, please.
My question, two questions. One question, mostly we've seen that calcaneum is a spongy bone, or
Yes.
mostly there is a pin tuck infection is more common in the calcaneum.
Yes, sir.
What are the measures you taken for prevention of the calcaneum in the pin in the calcaneum? Pin tuck infection in the calcaneum. One.
Yes,
Another,
sir.
what are the safe zone to put the wire in the base of the metatarsal and navicular, where there is arteria dorsalis pedis entered in the foot?
Yes, sir. So, sir,
How will you prevent?
sir, anything to be added, sir?
No, okay.
Okay, sir. I'm just thank you for your nice question. The pin tuck infection is very much important thing. You have to avoid it in all the places wherever the pin tuck infection is there. But in calcaneum, pin tuck infection is very dangerous because the bones is very spongy. And if precaution should be start from the area of selection of drilling, drill speed, wire configuration, wire configuration, and also the direction of the wire in fixation in calcaneum.
Direction of wire.
Direction of the wire. That is, if you put the two wire in a very small angulation and in a same plane, then these two wire, during the drilling of the wire, it will cause also the destruction of the bones. If it is passes very closely one after another, and when there is the side to side movement of the wire in the ring, this wire will produce the hole. This low configuration wire act as a cone and produce the hole in the bones. For these reasons, if you just put another plain wire like a console wire or even another direction wire in the safe zone, then you can avoid this type of fixation, this type of infection formation in case of calcaneum. You have to be very meticulous in wire direction and also the configuration of the wires, and also the post-operative caring of the wire pin tuck. It is also very important for prevention of infection in the calcaneum. And your second question is that, sir, if you go through my lecture, I put a line from the both the medial malleolus to the anterior web space of the first web space of the toe. If you usually the arteria dorsal space is just deep through the first, just at the beginning of the first intermetatarsal space. So if you just keep in mind the pulse and the keep in mind the anatomical just anatomical area of the wire to process the bones, then you can easily avoid the arteria dorsal spadies. It is not very difficult because it is very superficial. You can is very easily you can avoid it, sir. Sir, sir, do you have any complementary question you can add, sir?
Okay, thank you.
Thank you, sir. And I'm seeing that Dr. Rashid-Hassan have a second time he puts his hands up. Rashid-Hassan, do you have any question, Rashid-Hassan, sir?
Yes, sir. I have one more question, sir.
Yes, sir. What is?
Sir. Yes, sir. I have one more question.
Yes, sir,
Can I ask you?
Yes, sir. Definitely. Yes, sir. Please.
Okay. In your presentation, you have mentioned there are chance of talus dislocation of talus.
Yes, sir.
My question is why talus can dislocate it, and how why talus can dislocate it regarding ankle surgery.
Thank you, sir, for a nice question. Sir, this is a very interesting thing. You should, every ILIZAROV surgeon should know. If you mismatch the hinge, if you put a direction, if you put a distraction in a very wrong manner, then it can cause the most commonly the anterior subluxation of the talus. Even the talus can be subluxated posteriorly also, but common is the anterior subluxation. And usually when you put the distraction, if you remind your knowledge from your intermediate knowledge is that there are force vector, there are resultant force of if a force act on a surface, it can compress the force in a different direction and the resultant force in a particular direction. Usually when the distraction is working on a ring, there is a force act towards the talus. This force, if you go through my lecture and slide, you see that there is a F3 force that act on the talus. This F3 force, if it is more, then it can pushes the talus in the anterior direction. So this is the reason why the talus is usually dislocated. And if the talus is dislocated, the patient usually complain very severe pain. The patient can tell you that, sir, oh, I am okay for the last few days, but my pain increases a very very upper limit for the last few days. Then you go for the X-ray. And another clinical point is that usually this type of dislocation or this type of over distraction can also increase the foot swelling. Though sometimes the foot swelling during the distraction process is also indicate that your distraction force is disproportionate and something bad in the talus. So by this manner you can prevent and keeping always put the wire, put the distraction rod usually in posteriorly directed. So I think you got the answer. If you have any complementary questions, sir, you can add, sir.
No, sir. Okay. Thank you, sir.
Okay. Thank you
sir.
for participation. And I think, sir, we can go some foreign participant to have their comments about today's presentations. And I am unmuting the microphone of Dr. Madhu S. Ghali. Please introduce yourself, and if you have any question, comments, or if you want to communicate with the participant, you can do that. Sir, please unmute your microphone. I already unmuted it. Madhu S. Ghali, sir. Can you hear me, sir? Hello, sir. Can you hear me, sir? So I think if I get any hands up mark from my list, a participant, I can go to him directly. Otherwise, I am going to Dr. Nazmul Huda Shetu and Dr.
Yes.
Ghulam Mustafa for comments of the overall session, and then I will go back to my professor Mufakkarul Bari for ending speech and comments and advice and future invitation. I am going to Dr. Nazmul Huda Shetu. Shetu sir, can you hear me, sir?
Yes, I'm
Yes,
saying.
sir.
Okay, thank you for your brilliant presentation. Actually, you presented it very details, I think, and you also mentioned the placement of wire, placement of ring, and also the geometry of the foot very nicely. Thank you for your presentation. And last of all, I just for my clearance, I want to ask you a simple question.
Yes, sir.
When there is any mid-foot equinus,
Yes, sir.
but calcaneum and the talus in normal position,
Yes, sir.
then do you like to fix the talus with the tibial ring or the half ring for the calcaneum? Which one you do better, you think?
Sir,
Can you understand?
yes, sir, I understand question. It is a nice question, sir. Usually, our common belief, in my lecture, I already told you that our common belief is that calcaneum equinus deformity can only happen in calcaneum or in ankle. It is not true. If you just meticulously observe the X-ray of a paralytic foot or a deformed foot, usually the deformity is multi-directional, and even the calcaneal equinus deformity can happen in the hind foot and also can happen in the forefoot also. That forefoot is if the midfoot will break. Usually what happens in cavus foot, what happens is paralytic foots, that is the midfoot it break, it hindfoot is okay, all the parameters and all the things are okay, but the midfoot break in a certain manner, it gives you a false perception that it is a equinus deformity. And your question is that do you fix the calcaneum or talus during this type of midfoot correction of equinus? Usually my recommendation is that if you increase the lever arm to resist the correction force, it is always advised to you can do so. If you hold the calcaneum and talus in case of midfoot equinus, then it will increase your lever arm for holding or stability of the frame, and you can easily manipulate the forefoot because your base is very strong. And you know that I already told you that the anterior subluxation is a very common phenomenon, but the posterior subluxation also can be happen if you do not hold all the interconnected joints of the foot in a very secure manner. So I think my advice is that even if it is a simple deformity, if it is very correctable very easily, then sometimes you can put only forefoot frames and with the leg frames. It can be done, but you have to very meticulous about any dislocation is there or not. But my advice is that just hold all the bones so that your correction lever arm is more and more strong. I think you got the answer, sir.
Okay, thank you.
Okay, sir. Then please pass your comments about session because we are going at the end of the session. And from you, I will go to Professor Bari, sir.
I already, it's a brilliant presentation, and it will. I think it is it is very much helpful for those who are doing ankle or forefoot foot ILIZAROV. They will take the tips and tips, all sorts of information they can get from your lecture. Thank you for your nice lecture. Okay, thank you.
Thank you, sir. Now I'm going to Professor Mufakkarul Bari And
No.
yes, sir.
Okay. Yeah. No,
Yes, sir.
no question, no discussion.
Sir,
Finish everything.
yes, sir. Already we are just one and a half hour already we have covered.
Oh, 20 minutes already gone. Okay, okay.
Sir,
How many foreigners? Foreigners, I am looking 1, 2, 3, 4. 4 already listening.
yes,
3
sir.
Nigerian, one Indian, one Nepal. 5.
Sir,
Okay,
usually
thank you very much.
now
Huh?
Nigeria, it is working hours, sir. I don't know whether the Saturday
Now 11 in the morning there.
11 in the morning, sir.
11, yes, 5 hours difference.
Yes, sir.
I know, I know.
Sir, please conclude the session and have your
Thank you very much, Arif,
Yes, sir.
for a good discussion, good presentation, and most of the ILIZAROVians, they have participated. And I am also happy. I enjoyed your lecture. And those who are doing ILIZAROV for foot surgery, I am telling you, I don't know whether you have gone there or not. British Americans, even Koreans, they're frequently coming to ILIZAROV Center to learn the foot. And there are a lot of things that you cannot do. Even AO group, if you see the book of the AO group, they already mention all the time the ILIZAROV technique. And regarding one, I have forgotten, passing the wires in the toes for preventing the clawing. When you have a severe clubfoot, relapsed, neglected clubfoot, 1 or 0.5 millimeter wires you put. And frequently I always do that. Shetu and you have seen. And then you can, when you are giving distraction backside, you can prevent the further clawing. For that, you should have to pass the wires, 1 millimeter or 0.5 millimeter. And other things for cavers, you mentioned a steindler operation or plantarotomy, you call it plantarotomy. A tenotomy, double step tenotomy, 2-finger brace from the first one, second, you have shown from medial side or from lateral side. If you're expert, you can go from the medial side. Then, and gradually, you can correct. Slow, gradual, controlled, coordinated stretching gives you the full, beautiful correction. Even fibrous tissue, you can gradually lengthen. The surgery that you've done after the PMR, and then, as for example, long period passed, 9 years, 11 years, and more than that, if you do surgery in that age, you are inviting adhesions. Again, you are doing surgery, you are inviting adhesions. To prevent that adhesions, that ILIZAROV surgery can help you. Gradual, control, coordinating, whatever you like. And if you apply the differential distraction of the bones, you can gradually correct. So, nothing to be afraid. If you do ILIZAROV surgery, even if you prick the vessels, you go out and gradually do it. Tissue genesis, skin, muscle, bone, soft tissue, nerve, vessels, everything you can, convert, handle everything. So, thank you very much again, Arif, and participants. Thank the known faces. I don't see any new faces. Try to invite the new face. And next lecture will be ASM Abdullah. We are waiting for you. He talks very good. Somebody told me that he talks very good. And Abdullah will prepare a very good lecture. And from that day, my one will be deformity. That will be on 9th probably. Eh?
Yes, sir.
Arif? Okay.
Yes, sir.
So thank you very much. Thank you.
Sir,
Arif, thank you. Setu, thank you, Ronnie, Ghulam Mustafa, everybody, Abdullah, and all participants. Okay, bye.
Sir, with your permission, I want to answer a question. It is send it. It was sent it to me by doctors in the Nigeria. The question is that I think you can also see in the it is private question. Will you prefer to do fast in 50 years old with dislocation of the ankle for 3 years of duration?
Yes.
Yes, and
Yeah.
now having a severe equinus, and what you also need to do orthodesis. So this is a question from Nigeria. A good friend, Adel Kunle Abe Janjo, and he already sent me some cases of open fracture for my opinion a couple of days before. And now his question is that a very old neglected 3 years old duration equinus deformity who is dislocation of the ankle, 50 years old, and sir, you don't mention the skin condition and if any comorbidities like diabetes or other things. So otherwise it is though it is not said, so I think that it is normal. And my advice is that in this case, usually this 3 hours duration, this old age, and I will prefer to go for the orthodesis in the patient. And
orthodesis, yes. Before that, you will have to status of the talus.
Yes, sir.
Titanium technique 99. Go for CT scan, whatever the 3 years old.
Yes,
and
sir.
orthodesis at the age of 50, you can do that very easily by
Yes,
ILIZAROV technique.
Yes, sir. Definitely, sir. You have to go for the CT scan and other workup. And main thing is that if you are you have to do some sorts of opening of the ankle, and you have to cut the part of the devitalized part or the most porotic part or the loosest bone fragment, and you have to put the ILIZAROV and the compression of the part between the talus and the talus and the tibia will be very good one. And other thing is that if you have, as my professor told you, that if you encountered any kind of avascular necrosis, even the some part of the talus is already absorbed. If these things happened in this your situation, then you also can put a proximal osteotomy in the a distal corticotomy in the tibia, and you can go for bone destruction and also bone transport to get good union. Sir, this is my opinion. Do you have anything to say in this relation, sir?
Denude, lower end of the you told you, denude the lower end of the tibia, upper end of the denude the upper end of the talus, and both malleolus, and then 5-degree ankle dorsiflexion and a little bit varus. Fix with the ILIZAROV. Very simple. You don't need to put any hardware inside. Okay. Okay.
Yes,
thank
sir.
you very much. Thank
yes,
you.
Sir, he already sent some complimentary question that tendo Achilles is very short, so need not to elongate tendo Achilles and distract the tendo Achilles. He already mentioned. My advice is that if you just open your ankle mortise and just freshen the surfaces, and there will be a decrease of the length of the tibia also and some part of the talus also. And usually this resection usually cause you to get spaces for the correction of this type of equinus. Bone shortening can give you the space, so it is not a big problem. Usually you do not need to any type of tendon lengthening in this gradual lengthening or destruction of tendo Achilles in this situation. And but if you need anything like percutaneous tenotomy, and if anything is just preventing you for dislocation correction, you can lengthen it. It is not a big issue. But you did not need to do it gradually. You can do it acutely if the condition is favorable. So I think you get the answer, sir. Now I'm concluding the session, sir. Thank you, sir.
Thank you. Thank you.
Being with us, and inviting you for tomorrow our session with our Dr. ASM.
Day after tomorrow. Day after tomorrow.
No, sir. Tomorrow, sir.
Tomorrow?
Tomorrow.
7th.
Yes.
Okay. Okay. Tomorrow.
Yes,
thank you.
Tomorrow, sir.
Thank you.
Okay.
Okay, bye.
Thank you. Assalamu alaikum till now.
Wa alaikum assalam wa rahmatullah.